So I'm going to talk about community-based service provision for women affected by FGM. One of the things you'll notice is I'm rarely going to talk about the practice of FGM. I'm really trying to push us to start thinking about moving forward as service providers. What tends to happen is it almost gets pornographic, where people want to know about the details, why, how, what does it look like, all of those things. And so you'll rarely hear me talk about those sorts of details. What I really am trying to encourage is for increased access to health care for women, period, but particularly for women who have an issue that we're not dealing with effectively. So that's what I'm really going to be talking about today. One of the things that we often forget to think about is, how do we have the healthcare system that we have in Canada? We all know that we have supposedly a universal healthcare system. So everybody in Canada should be able to access healthcare equally, regardless of where you live in the country, regardless of how small the community is that you're in. We're all supposed to be able to access free healthcare in Canada. That's what we pride ourselves on. That ideology came out of a report in the 70s, the Lalonde report. And it was touted as the first modern government document in the Western world to acknowledge that there needs to be an emphasis on a biomedical system that's flawed. So using only a biomedical system to deal with illness is a flawed system. And Lalonde also emphasized that you need to look beyond traditional healthcare systems, so an illness model, if we wish to improve the health of the public. So universal healthcare came out of that ideology in the 70s. And that report also proposes what I think is the important thing that we need to understand, especially as healthcare providers, that public health interventions, government policies, and financial resources should be redirected and attention focused on the segment of the population with the highest level of health risk. So it's really interesting that in this day and in this time, we're still struggling to provide equitable health care to immigrant populations in Canada, when the universal health care system was implemented to specifically look at the most marginalized members of our population, the people with the highest risk in terms of illness. So I just wanted to kind of start there, because sometimes it's really important to not take our healthcare system for granted. That a lot of people worked hard to develop a healthcare system that they wanted to work effectively, but we now have groups of people who are coming forward to say, it's not working effectively for me. What are you going to do about it? What changes are you going to make? So along comes Women's Health in Women's Hands and the whole community health center model. And what I wanted to look at, and one of the questions that was brought up in one of our breakout sessions, was the discussion of FGC or FGM from women who are affected by the practice. So do they willingly bring this up? Do they talk about it? What do you see in your healthcare setting? So I pulled our statistics for last year, and we saw 3,000 women last year, and I pulled out the numbers for just our African population. So I looked at about 500 records. We have a wonderful data system in Ontario that can generate this for me, so I wasn't looking at the records manually. I'm dedicated, but not that dedicated. Top 10 reasons why African women came to seek services at Women's Health and Women's Hands. Number 1, depression. 2, health maintenance and preventative medicine. 3, psychological symptoms or complaints. 4, poverty. They came to the health center to address poverty and financial problems. 5, hypertension. 6, assault, harmful event. This is primarily rape, sexual assault, sexual abuse. 7, menopause. 8, pregnancy. 9, post-traumatic stress disorder. We have a large population of refugees, women fleeing war-torn situations. And number 10, diabetes. Under number 10, number 11, it should be 10/11 is HIV. FGM does not factor in the top 10, 11 issues that women presented with, meaning that they came to us for services. This is not to say that we don't have a large population of women who've undergone FGM, but it's not the pressing issue for them. A lot of these issues are chronic illnesses, chronic health illnesses. You know, when we look at the HIV rates, Women's Health and Women's Hands sees 25% of all HIV positive women for the province of Ontario seek their health care in one healthcare setting. And the same goes with a lot of the other chronic illnesses. We have to start looking at women holistically and moving away from focusing on the one issue that is of interest to us. It's the issue that, in my health center, when we first started, it's the issue that we were struggling with. Not that the women were struggling with it. We were struggling with trying to understand it, trying to provide better services. So you almost end up learning on the backs of the women who are experiencing the problem. When we also have to deal with all of these other issues that they're focused on. The other thing that's really important when you're looking at community-based models and working with particular populations is understanding what context are they living in within the community, so within the broader Canadian context. So one of the greatest determinants of ill health is poverty. So we all know that. We know that poverty is the greatest factor that will determine how healthy you are. When I pulled up just our statistics, our last census, we won't probably be able to do this again in Canada since we're getting rid of the long census form. So 2006 is probably the last time we'll be able to look at ethnic data. When I looked at African populations in terms of economics, this is the average income per household. For men, you could see the average Canadian, $36,800. For new African immigrants, it's $27,000. For women, $22,800 for the average Canadian, and for African, $19,000 is the average income. So we're looking at issues of economics, economic marginalization, and in terms of living below the poverty line, I mean, you can see the drastic difference. So 15% of all Canadian adults are living below the poverty line, meaning a household earning less than $15,000 per year. 39% of our African population is living below the poverty line in Canada. And when we look at children living below the poverty line, 18% of all children under 15 in Canada live below the poverty line. 47% of all African children in Canada are living below the poverty line. So when a woman is not coming to me focused on her FGM, but rather where she's going to be living, how she's going to be feeding herself and her family, trying to find better employment, I have to be able to refocus myself and address all of those issues along with any other health concerns that she has. The other thing in terms of looking at FGM within a violence prevention model, I have very limited resources to protect myself when my level of poverty is so high. I have very little resources to engage in activism or advocacy when I'm really struggling to just survive. So those are some of the things that we also have to be aware of, especially when we're developing models. In terms of immigration, I talked a little bit this morning about forced migration versus voluntary migration. The negative side of immigration in Canada is rarely discussed. We all, I shouldn't say we all, but many people believe that if you immigrate to Canada, your life is going to improve, especially for women. We have this perception that when women leave Africa in particular and come to Canada, they're free, they have all these opportunities, that life is going to be much better in Canada than it was in country of origin. But we never discuss the negative sides and the impact that immigration has on people. Loss of culture, loss of home, loss of tradition, loss of family, loss of status. Many of us come here highly skilled and then get to Canada and our education and experience is not valued. So there's so much loss that happens. The adjustment period, the settlement, the language adjustment, all of those things need to really be taken into account when you're working with particular populations. And something called the healthy immigrant syndrome is also not discussed. To immigrate to Canada, you have to go through a very, very stringent medical exam. People know this? Yes. So we're screening out people who are deemed not healthy enough to come to Canada. So the average immigrant is coming to Canada at a rate of about 5 times healthier than the average Canadian. The healthy immigrant syndrome, and there's lots of research that's been done on this, shows that within the first 5 years of immigration, the average immigrant's health deteriorates to significantly less than the average Canadian in 5 years. So we're also dealing with those situations. And then we have an enormous number of members of our community who do not have immigration status. And it's a very undiscussed, not documented, not talked about population of people who are here who have no access to health care because they don't have legal status in Canada and therefore can't access the health care system. So those are all things that we have to talk about before we even get into conversations about FGM and FGC, because the woman sitting in front of you is a whole person. She's dealing with all kinds of things. One of the other things that is not talked about often is how immigrant women are perceived. So they're often perceived as these very dependent, needy type of women. They're not perceived as resilient, strong women. So I always tell this story of the first Somali client that I worked with when I was a social work student many years ago. And this woman came to my office, and she had come to Canada with 5 children. She had left Somalia. Her husband had been killed during the war. She managed to get her 5 children to Kenya. She managed to get those 5 children from a refugee camp in Kenya to England. They were denied status, and she was able to get the 5 children from England to Canada. She was in a community called Rexdale, which is quite far from my health center, and she managed to figure out, without knowing how to speak English, to get from there downtown Toronto on the subway to my office and walked in for assistance. That's not a needy, dependent, weak woman. That's a very strong, resilient woman. So we have to start focusing on the strengths that these women are bringing with them, and maybe they might arrive at your place of employment or your healthcare setting requiring assistance, but my job is just to assist them on this leg of their journey. They're going to do well with or without me. If she could make it this far with her 5 children healthy and safe and intact. So we also have to look at power dynamics that are at play when we as healthcare providers feel that we are helping people who already have an enormous amount of strength and resilience. So it's really about how do I tap into that strength to help support, move this person's life forward. I want to emphasize the cultural sensitivity element. I went to a GTA hospital for a procedure that was a disaster from beginning to end. They expected me to change into one of those gownies and sit in public. And then she thought that a substitute for my headgear or hijab would be the nice little nursing cap, surgical cap. It's embarrassing for anybody. It was just so stupid, and then I have to parade through the entire hospital to go to the operating room, and she didn't get it. She didn't get it at all. This is a quote from a woman from a study that we just launched called Every Woman Matters, and we were looking at access and the difficulties that immigrant and refugee women were having in terms of accessing primary health care. And we were able to interview almost 250 women across Toronto about their experiences trying to access primary health care. And I like that quote because it brings in the whole notion that the nurse wasn't listening to this woman and understanding how she could accommodate her in a more effective way. And the person at the time when we spoke with her didn't feel at that time, and she's been in Canada longer, so she's telling us an old story, that she didn't have the language to be able to explain to the woman why it was important for her to keep her hijab on or to not have the open gown. Who likes to walk around in the gown, right? Let alone someone where modesty was actually really important for her. So we're dealing with, and for anyone who was at the launch, please forgive me. I know you've seen this slide already. I see someone smiling. The prevailing discourses in Canada about particularly immigrant and refugee women. They're underutilizing the healthcare system. No one is questioning, is there a problem with your system? That's why you're not seeing them there. It's about they're not utilizing it enough, right? We hear that word, underutilization. We focus on public education. If we just give them enough pamphlets and enough information, this is what's going to get them to the healthcare system. That they don't speak English. Once they get through the ESL program and can speak English, that's what's going to get them into the healthcare system. So it really focuses on that people have individual choices, they have individual differences, so they're different from some kind of norm, and that they have deficiencies. That's the message that we are constantly promoting in our healthcare system. The poster on your left, your healthcare be involved, it's in every hospital in Ontario. Your healthcare be involved. If you do something, your healthcare is going to be better. And then the thing we keep talking about, the shortage of doctors. So it's about how do you find a good doctor. Forget about how do you find a good doctor who is culturally competent, understands FGM, understands immigration issues, and all of these other things. I mean, how do you screen for that kind of doctor when we know we have a shortage already and people just need health care? They're not really in a position to be questioning how competent is that doctor. We don't have a system also that allows us to question our physicians in that kind of way. So in terms of accessing health care, there's this assumption that you identify that you have a health issue, you identify that you're sick, and you take that arrow straight across to the healthcare facility. So we know that that's not the case, and that there are a lot of things that are going to determine health, what we call determinants of health. They're going to determine how I get there. So I'll just take my race, for example. Race really determines what type of illnesses I might have, what I'm prone to. It's going to determine how I identify illness. So we keep hearing that women who have undergone FGM don't necessarily look at this as an illness that I need to go for medical attention for. It's going to determine how much resources, financial resources I have to pay for any extra services I need. It's going to determine, in a lot of cases, how close I live to healthcare facilities. It'll determine how I get there. Do I have money to pay to get there? It's going to determine how I'm treated when I get there. How welcomed am I going to be? How welcomed will I feel? How are the physicians, the nursing staff, how are they going to treat me? It's going to determine where I go after I leave the healthcare system. And I could go on and on and on. And I could change that race. I could change it to gender. I could change it to all kinds of things. There's all these things that are going to determine me getting from point A to point B, when in reality, we're going to all of these other places. I'm going to ask my mother for help. I'm going to ask my sister for advice. I might be lucky enough to be in one of the groups that was just discussed about, and I'll ask those women about healthcare services and issues. I'll go to a lot of other places, religious institutions. I'll go to all kinds of other places before I actually get to the healthcare setting. So those are things you have to think about in any kind of model. Where are women really going to for health information? Youth, they're on the internet before they get to a doctor's office. Libraries, all kinds of other places, right? Now, one of the stereotypes that I like to say about African people is we like to be educated. We value university. And a lot of effort and energy goes into us being highly educated. The population that we looked at, the highest level of education is extremely high, actually, compared to the average Canadian. Almost 30% of the women that we surveyed in our study, of almost 300 women, had college or university, highly educated. 32% of those women were unemployed, were unable to find employment in Canada. And the annual income for 64% of those women is under $15,000 per year. And if I go on to look in those households, when we looked at 64% living below the poverty line, almost 20% were supporting more than 5 people on that $15,000 between family here in Canada and family back home. So in terms of accessing healthcare services, 10.5 visits per year. I go see my doctor once for my annual checkup. Maybe I might have another visit for something else. But the average woman in this group was going 10.5 visits per year. Primary reason for seeking health care, chronic physical health condition, 45% of the population. So you can see what women are dealing with from this particular group of African women. Some of the problems they were having getting there, healthcare services were too far. Healthcare services closed when I can use it. If you think about the types of employment that new immigrants are engaged in, they don't have the luxury of just taking the day off to go to the doctor. So unable to get to the services because of employment commitments, no money to pay for travel to service, no money to pay for additional charges at service, no staff of my cultural background at the service was an issue, not enough time to go and deal with healthcare issues because of other commitments, family commitments. Women will make sure that the children are fine, that the husband is fine before they will ensure that they are fine. So these are some of the issues that you have to address when you're delivering community-based healthcare services. For any kind of program to be effective, it cannot be strictly about providing healthcare services. So at our health center, we do have a clinic that has doctors, nurses, dietitians, therapists, chiropodists, and all of those types of services. So we do provide direct primary health care. But what we found that it wasn't enough. It wasn't enough to change an entire system, particularly around the issue of FGM. So there are 6 things that we have in place for any program, for any health issue that we're dealing with at Women's Health and Women's Hands. Number 1, resource development. Anyone who's doing work with communities that are impacted by FGM understand there are no resources for women to access the information. So we needed to develop culturally appropriate, linguistically appropriate healthcare resources. So this is a booklet called Healthy Options for Women. It's actually, this one in particular is actually inside talking about HIV risk. Now you can't put HIV risk for women from impacted, no, that can't be the title of your book, right? So Healthy Options for Women, and it talks about all kinds of things, and it's translated into 6 African languages, so it's not linguistically translated, it's culturally translated for the different populations that we're serving. Number 2, education and outreach. We've talked a lot about that today. This is a forum that we had for the community. We do a lot of education. We go out into the communities and provide information directly. We do a lot of training with healthcare providers, and we have arrangements with all of the schools in the city that we're located in, nursing, midwifery, medical schools, all of those things. And we provide student placements to about 150 students per year, so that we're trying to educate as many people as possible so that we're not the only people doing this, that people are out in wherever I want to send my client. I have competently trained people that have at least experienced women's health and women's health. Care and support for women affected by FGM, and I've talked about that. I know you'll hear more about the clinical care later, so I'm not going to talk about the clinical care, but ensuring that we specialize in clinical care for this population. Research, and I'm really excited to see the research that's been presented just before me and earlier today, and the research that's coming up. It's really, really important. We do not have enough information about FGM in Canada, and it's really necessary to understand what FGM looks like in Canada. and I'm going to push for more research. This is a project that we participated in called Sisters, Mothers, Daughters, Aunties. Obviously, we're trying to appeal to women from the populations. And when we do this research, it generates new knowledge. It generates new information that helps me do my job better. Just an interesting fact with this study, one of the 300 women were surveyed. And one of the things that came up, we were talking about sexual health and looking at HIV risk and all kinds of things. Almost 10%, I think, of the population said that they shared needles, that this was one of their HIV risk factors, that they shared needles. And I went back to the research and I'm like, look, okay, I'm going to stereotype. I'm African. I don't think we're using needles, like IV drug use. Like when they put that question, they're talking about IV drug use. But when we went back to the community, the high rates of diabetes in African communities, and they were having multiple people in a household who were on insulin, and they were sharing the needles. That was a really interesting fact that came out of like a study on sexual health practices and things like that. So the research is really important because it also helps us understand how to improve systems and access to other services that these women needed. Training and skills development I've talked about. And finally, advocacy networks and partnership building. And I'm going to end here. And this one is really crucial for me. This is why I left Toronto to come to Winnipeg, because we have to start developing advocacy networks that are national. We have to be able to work together. Service providers need to be able to talk to each other nationally, and we need to start developing strategies that are national and research that is national. So that is the one thing I hope that we leave here at the end of these 2 days with, is some solid networks and some planning around how do we move forward. So thank you very much.